So thank you, David, and thank you, Remy. I'd like to also thank the conference organizers for asking me to speak today. And the focus of my talk will be on lessons learned from transient pediatric remission cases and the clues that they might provide to biomarkers of HIV rebound. So the past couple of decades have brought a lot of progress in terms of global eradication of pediatric HIV infection. For the non-pediatricians in the group, the good news is that new pediatric infections through mother-to-child transmission of HIV have been cut in half between 2001 and 2012, largely through the provision of antiretroviral therapy to prevent mother-to-child transmission. Since 2009 alone, over 900,000 new infections have been prevented in this way. But in 2015, there are still 3.2 million children under the age of 15 years who are living with HIV, and each year 1.5 million HIV-positive women give birth. Only 68% of these women receive antiretroviral therapy to prevent mother-to-child transmission, and as a result, about 240,000 children newly acquire HIV infection each and every year around the world. And that translates into about 1 new infection every 2 minutes. So for the pediatric community, a big goal is to not only prevent mother-to-child transmission, but to come up with therapeutic strategies that allow children to, that preserve children's health and allow them to grow into adulthood. So one big challenge to that, that we recognized very early in the epidemic was the very rapid tempo of disease progression in HIV-infected children. Median viral loads of over 100,000 copies per milliliter of plasma are observed over the first 2 years of life. And this is probably related to very high rates of viral production that have been documented and less robust adaptive HIV-specific immune responses. Now, knowing that mother-to-child transmission is the primary mode of transmission, we can readily identify infants at risk, and we can use nucleic acid-based methods to make early diagnosis. So that set us up in the mid-1990s to be able to initiate early treatment trials, and over the last 2 decades, we've learned a lot from these trials. In 2008, we learned that early combination therapy could markedly reduce HIV-related morbidity and mortality, and so as a result, early HIV diagnosis and combination treatment are globally recommended as standards of care. So with that, we've been able to assemble a number of cohorts, do a number of clinical trials, and in the context of those trials, we've been able to apply ever-evolving methodology to understand the effect of antiretroviral therapy on HIV persistence in children. Now, most of the measures that have been done have measured total proviral DNA, and that's because that's an assay that's relatively easy to do on the very small volumes of peripheral blood that are available from children. But those studies have taught us that the reservoir, the proviral DNA appears very, very early. So in the case of in utero infection, it's detectable at birth. In the case of intrapartum infection, it's detectable over the first week to 2 weeks of life. But if in the early antiretroviral therapy trials, baseline levels in those kids, this is kids under the age of 2 months, are fairly high. By then, they're up around a median of 1,000 copies per million PBMC, and they correlate with pre-therapy plasma RNA levels. Over the first year of therapy, these proviral DNA levels decay quite rapidly, about a median of about a log. And then over the next few years, we see additional decay of about half a log through year 4. Now, comparison, if you compare children who initiated antiretroviral therapy prior to 3 months of age and those who initiate treatment after 3 months of age, we see that the baseline levels are not significantly different. However, the decay curves are different, and children by year 4, children who initiate antiretroviral therapy under 3 months of age have significantly lower proviral DNA levels. Interestingly, HIV DNA measured at years 1 and 4 are correlated with age at which the plasma viral load drops below 400 copies per mil. Many of these trials did intensive RNA testing over the first year, and if you calculate an area, 12-month area under the curve, HIV DNA at 1 year is highly correlated with the HIV RNA 12-month area under the curve. So what that altogether, what that suggests is that the period of exposure to ongoing viral replication prior to control is highly correlated with proviral DNA levels over the first few years of life. Now, Deb Prasad and colleagues have looked at the latent reservoir and have demonstrated similarly that initiation of treatment prior to 6 months of age, and that's the red circles in this diagram, is associated with lower levels of cells that harbor infectious virus than initiation of treatment after 6 weeks of age. This reservoir is similar to the proviral reservoir. This reservoir decays over the first 2 years in early treated infants, but remains detectable in most infants through 2 to 4 years of age. Now, larger cross-sectional studies of children who have initiated antiretroviral therapy at varying time points and who have been suppressed and followed for 10 years or more have demonstrated that the earlier you start antiretroviral treatment again, the lower your proviral DNA levels. So children who started treatment prior and suppressed viral RNA prior to 1 year of age had a median proviral DNA load at 10 years or beyond of about 4 copies, which is just above the limits of detection of the droplet digital PCR assay that was used. And that was much lower than the median levels seen in children who initiated treatment at 1 to 5 years of age or after 10 years of age. Now, interestingly, we also measured 2-LTR DNA circles in this assay, in this study. They were detectable in about 20% of these youth, and proviral DNA copy number was higher in those youth with detectable 2-LTR DNA circles than in those with undetectable 2-LTR DNA circles, suggesting that there may be, some children may harbor ongoing viral replication, and that may contribute to replenishment of the reservoir. Now, something that became apparent over the course of these studies is that if you start children on treatment prior to 3 months of age and they clear viremia within the first 3 to 4 months, they lose HIV-specific antibodies and remain HIV antibody negative. Now, all children born to HIV-positive women will if they're born at term, will be HIV seropositive due to the passive transfer of maternal antibodies during the last trimester of pregnancy. HIV uninfected children will clear those antibodies by 15 months of age, as depicted in panel C of this figure. Children who undergo early treatment and control viral replication early on lose the antibodies in a pattern that's temporally similar to seroreverting children, and that's in panel A. And that's in contrast to children who either do not control viral infection or who are not treated until after 12 months of age, and that's in panels B and D. So we've looked at whether HIV antibodies can be used to distinguish children with particularly low levels of proviral DNA, and in this particular study, children who were HIV Western blot negative or indeterminate had much significantly lower levels of proviral DNA than children who were HIV antibody positive by Western blot. So this suggests that HIV antibody can be used as a marker to select for children who may have the lowest levels of proviral DNA load. Now, as I said, over the first 1 to 4 years of treatment, there's a very abrupt first phase decay in proviral DNA levels as well as in the latent reservoir, and that's about a log. And then there's a slower decay of about a half log to 1 log up through over the next 10 through 20 years. And after 20 years, 15 to 20 years, children, the proviral DNA levels in those children can approach the levels of detection of very sensitive assays such as droplet digital PCR. And this is occurring in the absence of HIV-specific antibodies. We've also demonstrated that it occurs in the absence of detectable HIV-specific T-cell responses. And so this decay of proviral load and latently infected CD4 T-cells in the absence of detectable HIV-specific immune responses suggests that if you treat children in early infection, you may avoid seeding of a longer-lived reservoir. And we've done studies to look at the contributions of various CD4 memory subsets to the proviral DNA load, and these studies have demonstrated that the majority of the detectable proviral DNA is in the transitional memory cells, and their contribution to the proviral load exceeds that of proviruses in longer-lived cells such as central memory cells. So as we've gone on and tried to treat children earlier and earlier, what we've observed is a further reduction in the proviral DNA loads, and that's depicted by the triangles, and those are the levels that are achievable using very early antiretroviral treatment, which is basically treatment within the first 48 hours to 1 week of life. And what you can see is that, again, those levels if you initiate treatment within 48 hours to the first week, you can drop proviral DNA levels further, and those proviral DNA levels are now, within those very first months of life, at the limits of detection of some of our most sensitive assays. Now, a case that demonstrated the very low levels that you could achieve and their potential relationship to remission was illustrated by the Mississippi baby. And this was a case of a baby, I think as many of you are aware, who was infected in utero and who initiated antiretroviral therapy at 31 hours of age. Antiretroviral therapy was continued through 18 months of age and discontinued against medical advice. Now, this child remained clinically healthy and without without evidence of HIV viremia through 28 months of age, at which time HIV RNA was again detected. But up to 1 month prior to the viral rebound, we were unable to detect HIV RNA in using routine or single-cell RNA assays. We weren't able to recover replication-competent virus. This baby had undetectable HIV-specific antibodies or CD4 and CD8 T-cell responses. And all of this occurred in the absence of host factors associated with elite control, suggesting that it really was this very intense antiretroviral therapy that was initiated early that was responsible for these very low levels of latent reservoir and the remission. So this child rebounded at 46 months of age. Interestingly, when we went back to a sample that was obtained 1 month prior, when the child came in for a routine visit and was healthy, we were able to detect RNA by single copy assay at 9 copies per mil. This child rebounded at 46 months to over 10,000 copies per mil, which was confirmed, but the child has since suppressed very nicely on antiretroviral therapy. Now, with the rebound, the proviral load went from barely detectable. It was occasionally detectable using an assay with a limit of detection of about 2.6 copies per million cells. And the peak level was about 548 copies per million cells. With therapy, that has decreased by about a log to a most recent measurement of 52 copies per million PBMC. Interestingly, though, on having done a couple of viral outgrowth assays, we have been unable to recover a replication-competent virus. So with the breakthrough, the viral breakthrough, this child has made a full complement of HIV-specific antibodies, and that includes antibodies to HIV envelope, GAG, as well as to P31 and RT. Those antibodies have waned with the control of viral replication on antiretroviral therapy. We looked at antibody avidity, and that was relatively low when antibodies were first detected. That increased over time and has begun to decrease again with control of viral replication. And altogether, the pattern of the antibody formation as well as the antibody avidity studies suggest to us that this is more akin to a primary response than to a secondary response. So there have been a number of children now who have been treated with very early therapy and who unfortunately have experienced breakthrough when antiretroviral therapy was stopped for one reason or another. The Mississippi baby I've just described. There's been at least one baby from Canada and a couple babies in the literature from Milan. And what's interesting is that all of these children had undetectable or very low-level detection of cell-associated DNA in the peripheral blood. And it's estimated that the reduction in the latent reservoir was at least 3 logs, and yet all of them experienced rebound. The time to rebound was under a month in the Canadian and the 2 Milan babies. The Mississippi baby experienced the longest period of remission at 27 months. If you look at the factors that have been thought to be important for determining latent reservoir size and time to remission, we find that the Mississippi baby was suppressed most rapidly on antiretroviral therapy, so under a month. All of the other infants took a little longer, suggesting that while we weren't able to detect proviral DNA or replication-competent virus in their peripheral blood, that they might have harbored a larger reservoir that allowed them that caused rebound more rapidly. In addition, cell-associated RNA was detected in the Canadian baby. T-cell activation and HIV-specific immune responses were detected in the babies from Milan, suggesting again that there might have been some ongoing viral replication, and that may have contributed to the more rapid rebound. So I think in summary, very early combination antiretroviral therapy appears to alter HIV persistence in children. It limits proviral and replication-competent reservoirs. The size is correlated with the rapidity of control of HIV replication. The proviral and replication-competent reservoirs decay rapidly over the first year, about a log, and then there's a much slower decay with prolonged suppression of HIV replication over a decade or beyond. This decay in HIV proviral reservoirs over time in the absence of HIV-specific immune responses suggests that very early combination treatment can markedly limit infection of long-lived cells, and indeed we found that the contribution of the transitional memory CD4 T cells to the proviral reservoir exceeds that of the other longer-lived cells such as central memory cells. I think what these studies have also told us is that potential markers for low-level proviral and latent reservoirs include plasma RNA below the detection limits of single-copy assays, the lack of detectable 2-LTR DNA circles, absence of T-cell activation, and a lack of HIV-specific immune responses, including antibody responses and CD4 and CD8 T-cell responses. So these are all things that are going to be looked at in future studies. I did want to say before I close that very early treatment and early treatment and this very restricted viral replication with very low levels to absent levels of circulating provirus and replication-competent virus, I think is a hallmark of very early treatment and early treatment. But I think at this conference we've heard of another type of, another potential pathway to treatment, and that is in a post-treatment, pediatric post-treatment controller. I think many of you know that about 5 to 15% of adults appear to be post-treatment controllers if they are treated during primary HIV infection. They are characterized by a low-level T-cell activation and detectable HIV-specific immune responses, and low but detectable circulating HIV DNA level. And interestingly, it does appear in some to be progressive decline over time in these proviral DNA levels. In this pediatric case, this child was infected despite infant ARV prophylaxis, received combination treatment between 3 months and 6 months, and was largely, for a long time, had undetectable plasma RNA except for 4 blips, detectable blips at 1 to 11 and 14 years, but more recently has had plasma HIV RNA levels that are below the detectable limits of single copy assays. Now, interestingly, this child has circulating levels of proviral DNA that vary between 125 and 136 copies per million of PBMC, and this child is HIV antibody positive. So again, a very different from the children who have received very early treatment or early therapy, but I think the hope is that further workup of this child may yield additional clues as to factors that may contribute to post-treatment control. So altogether, I think what we've tried to do over the last several years is to apply the tools, many of which you'll hear a little bit more about later, to populations of children who have undergone very early or early treatment to really understand what that therapy does to the latent reservoir. We, I think, have some ideas or hypotheses about markers that can be used to predict which children may achieve sufficient control to allow a period of remission off treatment. And those are going to be important when we look to apply. So impact P1115 is a new protocol that has just opened over the last year, and it is investigating the effects of very early intensive treatment on remission. And treatment discontinuation will be a very important proof of concept for that study. But in order to, I think, undertake that with any degree of confidence, we're going to have to do some additional work over the next year on refining markers. Just to say that that is all in progress, and I think we'll be learning a great deal from these studies. But I'd like to leave you with the thought that HIV positive children, infants and children with persistent suppression of HIV on combination treatment, are excellent candidates for additional strategies aimed at remissions because of their very low levels of proviral and latent virus. And they may be particularly suited for therapeutic vaccine protocols because they have normal immunity, normal CD4 counts. We've demonstrated that they make normal responses to routine childhood vaccines and environmental or antigens or other infectious agents. They have absent HIV-specific immunity, and they have limited viral diversity. These children, I think, will be very informative in terms of cure strategies. So before I close, I'd like to acknowledge all the children and their families who have participated in the many studies that we and others have done that are informing the field. I'd like to acknowledge my close collaborators, Hannah Gay and Deborah Prasad, members of my lab who've done the work, collaborators Matt Strain, Danielle Murray, Doug Richmond, and Tae-Wook Chun, and funding from NIAID, NICHD, AMFAR, our CFARs,